Hi, my name is Peter Tebben. I am an endocrinologist and I work at Mayo Clinic in Rochester, Minnesota. I spend the majority of my time in clinical practice seeing both children and adults with metabolic bone disorders. And over the next 15 to 20 minutes, I'd like to talk about a rare condition called tumor-induced osteomalacia. And we'll talk about how to diagnose this condition and management strategies for this disorder. Over the next 15 minutes or so, we'll talk about what are the clinical features of tumor-induced osteomalacia. So when should we suspect this in one of our patients? In order to form a framework of how to approach the diagnostic strategy, we'll talk a bit about phosphate homeostasis. And then we'll finish up with discussing management strategies for patients who we suspect or we know have tumor-induced osteomalacia. I think a good way to introduce this topic is just to introduce you to a patient that I met several years ago. This is a 70-year-old gentleman who had symptoms for about 7 years. This started with right knee pain that subsequently went to his other knee and then both hips, and then his feet hurts. He developed pretty profound muscle weakness to the point he needed a cane to walk, and then for most of his activities, he required a scooter to get around. And although he was 70 years old, he was accustomed to being quite active, doing many activities, and had enjoyed dancing with his wife, and was clearly quite disappointed he wasn't able to participate in those activities anymore. He'd had numerous imaging tests, MRIs and CT scans and laboratory tests, and at one point diagnosed with vitamin D deficiency, treated with vitamin D, but this didn't help his weakness, didn't improve his pain, and didn't help his fractures. He met a new endocrinologist locally who measured his serum phosphorus. And if you don't remember anything else from this discussion today, remember to measure serum phosphorus concentrations in patients with unexplained musculoskeletal symptoms. And of course, the serum phosphorus was low. This is a hallmark laboratory finding in patients with tumor-induced osteomalacia. And the diagnosis was initially entertained. So what is this disease? It's a rare paraneoplastic condition characterized by chronic low phosphorus and the osteomalacia that results. The offending tumors can be found anywhere in the body from head to toe, and the classic features are just like you heard in the patient I described, having muscle weakness, bone pain, and fractures. And these are features that are consistent among any cause of osteomalacia. A delay in diagnosis for several years is the norm, unfortunately, as it was in my patient. So why should we care? This is pretty rare. Fewer than 1,000 patients have been described in the medical literature. It's important because it can have severe consequences and devastating impact on patients' lives. And tumor-induced osteomalacia is a curable disease if we can find the tumor. So let's talk a little bit about phosphate homeostasis. What are we actually measuring when we measure a serum phosphorus concentration? Well, we're measuring what's in the extracellular pool, and that's made up of several different factors. What comes into the system through our gut, so the phosphate content in our food, or supplements, or a phosphate binder, are all things that may impact the input side of the equation. Once it's into the system, it can move around. It can move into the bone, it can come out of the bone through bone formation and bone resorption, or it can move into the intracellular space. But the major regulator of phosphate homeostasis and what really fine-tunes the system is the kidney. Parathyroid hormone we think of as a hormone that generally regulates calcium metabolism, but it plays a very important role in phosphate metabolism as well. And in the proximal tubule, it regulates the expression of sodium phosphate transporters. And this is why in patients who have hyperparathyroidism from any reason will often have low serum phosphorus levels because you lose the ability to reabsorb that phosphorus in the proximal tubule. So more of it goes out in the kidney and the serum levels are low. More recently, FGF23 is a phosphatone or phosphate regulating hormone. It's produced in the bone. It has been shown to be a major regulator of phosphate metabolism in normal physiology. And similar to parathyroid hormone, FGF23 can impact the expression of these sodium phosphate transporters in the proximal tubule. And just like parathyroid hormone, if you have excess amounts of FGF23, then you lose the phosphate transporters and lose the ability to reabsorb phosphorus. And therefore, the urine phosphorus goes up and the serum phosphorus goes down. In contrast to parathyroid hormone, FGF23 has the opposite effect on vitamin D production. So parathyroid hormone increases calcitriol or 1,25 dihydroxyvitamin D production, whereas FGF23 decreases production. And this is a tool that we can use, a difference that we can use as we look at the pattern of laboratory tests when we're trying to figure out what the underlying cause of hypophosphatemia might be in a particular patient. So with that in mind, sometimes we'll go on and I could show you a long list of the differential for hypophosphatemia. I think that gets to be a bit confusing and overwhelming to just look at long lists. And I like to break it down into something more simple. And when I think of a patient who has hypophosphatemia, there are really only three options. It's either not enough coming into the system, it's moving around once it's inside the body, or there's too much going out. Now, within each one of those categories, there can be several different possibilities, but I think if we break it down to those three basic principles, it's easier to work through our differential diagnosis. For patients that have not enough coming into the system, or for those who have redistribution of the phosphorus in the body, the majority of the time, we can either make the diagnosis or be pretty confident of the diagnosis just based on history alone. If they have an unusual diet, very low in phosphorus, or they're taking phosphate binders, we're going to fit them into that not enough in category. Or if they have a malabsorption syndrome like inflammatory bowel disease or short gut, they're probably going to fit into this category of not enough phosphorus coming into the system. For those with redistribution, insulin therapy for DKA is a frequent one that endocrinologists will come across. The anxious patient in the emergency department who's hyperventilating and has an acute respiratory alkalosis will cause an intracellular shift of serum phosphorus and will have transient lower levels. Or a patient who recently had a parathyroid surgery for primary hyperparathyroidism and they've developed hungry bone syndrome. This most frequently happens for patients with quite severe hyperparathyroidism. Again, most of these things we'd be able to identify with the history alone without having to do any fancy testing. And then we come to the group where tumor-induced osteomalacia fits in. And this is that bigger category of too much out. And again, I like to break this down into a few different options. This could be a parathyroid hormone-mediated process, a fibroblast growth factor 23 mediated process like tumor-induced osteomalacia, or a primary defect in that proximal renal tubule, renal Fanconi syndrome, or a mutation in the actual sodium phosphate transporters themselves. So now we have a patient in front of us with low phosphorus, and we're wondering, could they have tumor-induced osteomalacia or one of these other conditions? The way I would approach this is, like all other patients, take an accurate history. And with that history alone, we'll be able to identify those patients who have a redistribution problem. If that's not the cause, then my approach, and there are other approaches to this, but my approach is to take a look at their urine phosphorus. If they have very low or undetectable urine phosphorus concentrations, then we can be pretty confident that they're going to fit into the not enough coming into the system. This would be an appropriate response of the kidneys to hold on to phosphorus as avidly as they can if there's not enough coming in to the system in the first place. If their urine phosphorus is high, so they're excreting more than they should in the face of hypophosphatemia, the next lab I'll look at is their parathyroid hormone. If it's high, maybe they have primary or secondary hyperparathyroidism. Maybe they have vitamin D deficiency or a calcium deficient diet. If their PTH is normal, then I look at their active vitamin D level, that 125 dihydroxyvitamin D. That's not the one that we typically think of when we're looking for vitamin D deficiency, but can be very helpful in this scenario. And if you remember, FGF23 inhibits the production of 125D. So if it's inappropriately normal or low, we probably have an FGF23 mediated problem. If the 125D level is high, this is most likely not an FGF23 mediated problem. And the reason I lay out this algorithm this way is, although we can measure FGF23 on a clinical basis, not everybody has access to that test. And so I want to lay out an algorithm where measuring blood and urine phosphorus, vitamin D metabolites, parathyroid hormone, we can really narrow our differential diagnosis. So if we look at that pattern that we would expect of laboratory tests in a patient with tumor-induced osteomalacia, of course, they'll have a low serum phosphorus concentration. Most of the time, calcium levels are normal. Parathyroid hormone is occasionally mildly elevated, but often normal. Their 125D level is either inappropriately normal or low. And FGF23, if you happen to measure it, will be inappropriately normal or high. And of course, their urine phosphorus would be elevated. In the face of low serum phosphorus concentration, our kidneys should hold on to at least 95% of the filtered load. So if we have a patient with this pattern of labs, I think it's important to go back to that list of causes of FGF23 mediated low phosphorus to make sure we don't overlook something before we embark on extensive imaging tests looking for a tumor. So thinking of the heritable causes, X-linked hypophosphatemic rickets or autosomal dominant hypophosphatemic rickets. Occasionally in families or patients, the clinical phenotype can be quite mild and maybe not apparent during childhood and show up later on. So it's at least worth asking the question, could they have this condition? Is there a family history suggestive of other people with hypophosphatemia? Importantly, another more recently described phenomenon is hypophosphatemia developing after iron infusions for anemia. This doesn't seem intuitive, and it seems to be more of a problem in patients receiving iron carboxymaltose infusions that can raise FGF23 levels. This is a transient problem, but it can last for weeks or months, and patients can be quite symptomatic and require treatment. So remember to ask about recent iron infusions, and if that's the case, that may be the underlying cause, in which case you wouldn't have to go on and do more extensive testing. So if we've ruled all of those things out and we are suspicious that a patient has tumor-induced osteomalacia, by far the most important next step is to hunt for that tumor. And as I mentioned before, these tumors can be anywhere from head to toe. They can be in bone, they can be in soft tissue, and they can be tiny. They're notoriously difficult to find. There are many case reports and case series that have been done looking at various ways to identify these tumors. And the more recent literature would suggest that imaging studies that utilize the somatostatin receptor are more sensitive in finding these tumors. And in particular, gallium-68 dotatate PET-CT scans seem to be the best. Although they don't find all tumors, they seem to be better than other imaging modalities. So a gallium-68 dotatate PET-CT scan, I would put at the top of the list of functional imaging studies. And it's important to work with your radiology department to have them look head to toe, not cut off the arms and the legs as sometimes can happen. We need hands and feet included in those images because again, these tumors can be anywhere. Octreotide scans can be helpful. Occasionally an FDG PET-CT scan or whole body sestamibi scanning has also identified tumors that had previously been elusive. Starting with functional imaging that looks at the entire body is important, and anything that's noted on those studies needs to be followed up with anatomical imaging, typically an MRI or a CT scan, sometimes an ultrasound. Even before we go down the imaging pathway, doing a full physical exam can be helpful and sometimes preclude the need for these imaging tests in the first place. I recall a patient I met about 15 years ago with tumor-induced osteomalacia. And as an aside, he had mentioned a skin lesion on his shoulder that had been getting bigger over time. and the size of the skin lesion correlating with his symptoms getting worse. And he went to dermatology, a biopsy was performed and proved that that was the offending tumor, which was subsequently removed and his tumor-induced osteomalacia treated. Sometimes venous sampling has been helpful if there are multiple tumors identified to try and figure out which tumor is the offending growth. But in the absence of seeing anything on functional or anatomic imaging has not been terribly effective. So what about treatment options? By far and away, surgery is the most effective and the one that we should always strive for. But there will be patients where we can't find the tumor, or the tumor happens to be in a place that we can't resect. And if that's the case, medical management should be our next step to try and alleviate the symptoms of the patient. And now we have two options: phosphorus and calcitriol, or active vitamin D supplementation, or the recently approved anti-FGF23 antibody therapy. You may be familiar with this treatment, burosumab, for patients with X-linked hypophosphatemic rickets. It has been shown to be effective in patients with tumor-induced osteomalacia who have tumors that can't be resected as well. By far and away, surgery is the best treatment because we can cure the disease, but that requires that we find where the tumor is located. And if we don't initially find where the tumor is located, we will move on to medical management. But it's important to remember, if we don't find it on our initial look with the dotatate scan or actreotide scan or whatever scans we tried, that 6 or 12 or 18 months later, periodically we re-image. Just because we didn't find it the first time doesn't mean we won't find it in the future and have a potential option for cure. If we're going to use phosphate and calcitriol, and historically this is the medical management that we would use in patients with unresectable disease, and it can help improve symptoms, heal fractures, improve weakness, and take away pain. Although it's a treatment, it's not a cure, as surgery would be. And you can see the typical dose range for phosphorus and calcitriol that we might use. Sometimes we need higher doses. And our goal of treatment isn't always to make the serum phosphorus perfectly normal. That's great if we can. But really our goal with this treatment is to heal fractures, to take away pain, improve mobility, and to treat the muscle weakness. The trick with this therapy is to get the right balance of phosphorus and calcitriol. If we give too much phosphorus, we'll typically cause GI symptoms, diarrhea. We can cause hypocalcemia, or even induce secondary or tertiary hyperparathyroidism. And remember, that high PTH is going to drive the serum phosphorus levels down even further. On the other hand, if we give too much calcitriol, this will cause hypercalcemia, hypercalciuria, kidney stones, nephrocalcinosis. So this therapy requires frequent monitoring, not only to make sure we're accomplishing our treatment goals and helping the patient feel better and live better, but also to make sure that we're not causing complications from the treatment itself. So what about anti-FGF23 antibody therapy? As a review, FGF23 is normally made in the bone. It has its impact in the kidney to regulate the levels of sodium phosphate transporters and keep things in balance between phosphate reabsorption and phosphate excretion to keep the serum levels normal. Now, if we have a tumor overexpressing FGF23, we'll have higher FGF23 concentrations. We'll lose the ability to reabsorb phosphorus in the kidney because those sodium phosphate transporters aren't expressed anymore. And the urine phosphorus concentrations go up and leads to the clinical phenotype of this disease. With anti-FGF23 antibody therapy, we don't take away the high FGF23 levels, but we can have an impact on the function of those high FGF23 concentrations. We can restore some of those sodium phosphate transporters in the kidney, so now the patient's able to reabsorb phosphorus more efficiently in the kidney, restoring serum phosphorus levels to a more normal range. And this has been shown in recent abstract form to improve fracture healing, to improve muscle strength, and to reduce pain. So what are the takeaways from this? Number one, just consider the diagnosis. We see a lot of patients who have unexplained musculoskeletal symptoms. Measuring a serum phosphorus is by far the most important aspect because it will tip us off to what the underlying condition might be. Serum phosphorus levels, because they're not part of standard complete metabolic or basic metabolic panels, often gets overlooked. And I think a common reason why so many patients have a long delay in diagnosis. Even though this is a rare condition, it can have devastating impact on a patient's life. So measuring a serum phosphorus, considering the diagnosis, and then going through that algorithm that we had discussed to try and come to a conclusion as to the underlying cause of their hypophosphatemia. And if they do have tumor-induced osteomalacia, trying to find that tumor so a surgical cure is an option. But if not, we do have medical management therapies as well. Thank you for your time.